Welcome. Come with me. The doctors will see you now.
Welcome back to Fast Talks with Family Docs. I'm Dr. Veer Vidala.
And I am Dr. Phil Palmer. And tonight we continue with another episode exploring what the world of family medicine has to offer and the physicians who are defining and even redefining its boundaries. Today we're excited to be joined by Dr. Whitney Crowe, a board-certified family physician at Integris Health, who really is a true example of the versatility and broad scope of our specialty. Dr. Crowe's practice spans far beyond what might be considered traditional primary care. She's not only passionate about outpatient family medicine, but she delivers babies. She performs C-sections. She provides full spectrum reproductive care, including vasectomies. Her procedural skills don't stop there. She does derm procedures and joint injections, and even specializes in menopausal care with additional credentials from the Menopause Society as a result of her training. Her approach to practice is a powerful reminder of what family docs are trained and capable to do. Dr. Crowe, thanks for joining us today.
Thank you so much for having me. I'm really excited to be here.
Awesome. Dr. Crowe, thanks again. I got to say it too, because I'm really excited about this episode. You specialize in menopausal care, and I think, primary care, I do outpatient primary care primarily, and I do, obesity medicine as part of like my hybrid practice. And I have so many patients, a lot of women who are going through menopause, and sometimes I feel like I'm not equipped enough to help them with that transition process. What led you to pursue this additional certification, and how do you incorporate that into your primary care practice?
Yeah, so I got really lucky and had an attending in residency and a mentor. She was wonderful. She was an outpatient gynecologist who realized the need for menopausal care in her patients.
Yeah.
And so she started researching it and how she could, learn more about it, because even she felt like she didn't know enough about menopause or how to really help these women. And she found the Menopause Society and introduced it to me as well as a few of my co-residents and some other attendings, and asked us to take the course with her and study for the exam. And so we all did it together.
That's great.
That's awesome.
And that's how I ended up practicing menopausal medicine.
Yeah. So for those who are interested, how long is the course, and how do you get certified, I guess?
So I believe it's still the same, but they offer 2 tests a year. And it's just kind of a self-study course, right? They have a book that you can purchase, you study it. We actually divided up chapters and came up with practice questions and divided them between all of us and would go through them together and talk about it. And then we all took the test, not together, but around the same time. And that was really it. And you can recertify every so years by taking so few years by taking the exam, or you can do enough CME in menopause to where you just get recertified. So I'm coming up on my recertification in December, I believe, and plan to go to the Menopause Society's conference in Orlando this year.
That's awesome.
Okay.
Yeah.
So it might not be the right term to ask if that training changed your practice, since you got the training as a resident, but so maybe I should say, how has it influenced your practice and your approach to women's health and hormone therapy?
Yeah, so I definitely think it has shaped my practice a lot. In Oklahoma, there are only a few menopause practitioners. And when you become a certified menopause practitioner, your name gets listed on their website.
Okay.
So I definitely have a lot of patients seeking me out for menopausal care specifically. So I think, as a new physician coming to a new practice, it has helped to increase my patient load, which I appreciate. So I kind of have like a 50-50 practice. I have my regular family medicine, and then I have my people that are seeing me specifically for menopausal care and hormone therapy.
Okay.
So with your additional training, sometimes people in primary care, if we're looking into a woman transition to menopause or thinking about hormonal therapy, sometimes we'll just refer to OB-GYN or consider risks and benefits and start it on ourselves. But like, how has this additional training, I guess, like, highlight some of the misconceptions that primary care docs may have, and what are some of the big ones that you think our listeners should know?
Yeah, well, I think
you just need estrogen, right? Estrogen and then a little progesterone if you still have your uterus.
Right?
I think the biggest misconception is that patients and sometimes even physicians think that, menopause is natural, right? It's just a physiologic thing that anyone born with ovaries is going to experience, which is true. But there's a lot of natural things that happen in life that we don't make people suffer through,
That's
right?
true. That's true.
Medicine is changing and is amazing. It's great that we have created these hormones that we can give to women to mimic, right? We used to call it hormone replacement therapy, but replacement's not really a great word because that means they are absent in something that they should have. And that's not true. Physiologically, they should no longer have estrogen and progesterone. So now it's just hormone therapy.
Okay.
Right? So the biggest misconception is that it's normal, it's natural, you should suffer through this. No, we have great medicine, and it has been shown to be pretty safe in most patients to give it to them. And if we can make this transition a little bit easier for women, then why not?
Oh, and so is it really medicating, I'm going to use that term in air quotes for those who are listening. Is it medicine for a transition? Is it medicine for more of a years-long transition? Is some of this a lifetime approach? I know the WHO study has influenced a lot of things from back in the 90s when we were doing stuff.
Yeah. So previously it was kind of like, oh, you should be on it within 1 year of menopause, which is still a reasonable approach to it. But, we should start talking about stopping at 5 years, really 10 years. Now it's more of a risk-benefit discussion with your patients. If they have noticed a ton of benefit from this, they're sleeping better than they have been for the past 5 years. They're no longer having hot flashes. Their mood's better. Their joint pain is even improved. They remain low risk. There might be more benefit to hormone therapy long term than we realize.
Okay. Yeah, because we talk about risk of osteoporosis, and then a lot of women come in saying, "I can't sleep," and I think there's a lot of validity into learning more about this and being comfortable because it beats trazodone and Ambien.
Yeah,
right?
Absolutely. Yeah. And that's, I think one thing is just counseling patients about it, right? As family doctors, we talk to our young teenagers about puberty, right?
Yeah.
We talk about the changes they're going to experience. Sometimes we even offer birth control to our, kids going through puberty to help with their, abnormal periods and stuff.
Right.
But yet no one really counsels women on this change that they're going to go through. And I heard one of the famous OBGYNs that's really well known for menopause, she calls it puberty in reverse. So, and it is, right? It's exactly, it's puberty in reverse. And so it's something we should just feel comfortable counseling patients about, even if we're not quite comfortable giving hormones. And there's a lot of other medicines besides hormones that you can offer to these women too.
Yeah. So, and I think a lot of times people think, well, it's a woman, so we're talking about estrogen and progesterone. But we've also talked previously that there's some research even looking at testosterone in perimenopausal and postmenopausal women. Talk about that a little bit.
Yeah. So the Menopause Society does recommend the use of testosterone in appropriately screened women who have hypoactive sexual disorder in the menopausal state. Now, it's not yet FDA approved, so it gets a little bit more difficult to prescribe, but there is some evidence that it can be helpful to those women. You have to make sure you've looked at all the other reasons that women may be having low libido or, low sexual desire, and they have to be low risk, right? Because there are risks that come along with both the estrogen and progesterone as well as the testosterone. But yes, there is some evidence that it can be useful in these women. They do need to be monitored. You're not trying to get them to male level testosterone. And then you also need to monitor that, well, did your symptoms improve? Because if not, we need to take you off of this.
Yeah. What are your thoughts about testosterone pellets? I've seen that a lot in, other providers, maybe some of the wellness clinics that are doing hormone replacement. And I read that there's some side effects, like clitoromegaly is one of them, and that can be pretty profound, right? Is there any evidence to pellets, or is that something you provide?
So I do not do pellets. Okay. I try to follow the Menopause Society and their guidelines completely. And they do not recommend for any hormone pellets, not just testosterone pellets, the estrogen pellets as well. They're not well studied. We don't know how long they last. They also cost a lot of money. And that's one thing I tell my patients is you shouldn't be paying hundreds of dollars for your hormones. Hormones are FDA approved. The estrogen and progesterone are. We have safe, formulations that we know how they work. We know the risk that come with them. And so why pay a lot of money for these hormones that aren't well studied? This lab work that's not well studied either, right? Like, I don't need labs to tell me that someone is menopausal.
Yeah.
You tell me you haven't had a period in a year and you're having hot flashes that are waking you up every few hours, like, it's a no-brainer to me. Now, I should look at other medical causes, right? Like, I need to get a TSH, make sure there's not a thyroid issue.
Right.
I need to make sure you're up to date on cancer screening and all these other concerns that we have as family doctors.
Yeah.
But I don't need an estrogen level to tell me if you are in menopause or not.
Yeah. Wow. Okay.
So in the field of family medicine, there's obviously a great breadth of data that needs to be covered in residency training.
Yeah.
And so do you think there's a need to change a focus of menopausal care in family medicine? And if so, how should we look at restructuring that as we educate residents?
Yeah, I think absolutely. I think all family doctors should feel comfortable talking to women about menopause and their treatment options. Whether or not someone decides to treat menopausal women when they go into practice, obviously people get to decide the scope of medicine they want to practice, but I think it's something that's very reasonable. We are all about continuity of care, and this falls into that scope of continuity of care. We talk about caring for women from birth to death. Well, this is part of that. So we should feel comfortable doing it. I think, one thing we have done is we have started offering an elective for residents that want to focus more on menopausal care. But this is easily something that could be added to their women's health rotation anyways.
Right.
How, as a guesstimate, how much time did you spend? And if you mentioned this earlier, I apologize, I missed it. But if there's docs in practice who are like, I would want to maybe connect with the Menopause Society and try and get this additional education for myself, how long, roughly in hours, is that module of prep kind of thing? Is it a couple of months and scattered over evenings that you did it to make it happen?
We did it in a few weeks. We met like, I can't remember what day of the week it was. It was like a Wednesday evening for like 1 to 2 hours. We would bring dinner, we'd have dinner, we would talk about the chapters that we read, do some practice questions, and that was it.
Okay.
I mean, I had some individual reading, at home before bed. I would maybe read a few chapters.
Yeah.
But other than that, it's very doable whether you're in residency training or you are a practicing physician and trying to add something else.
Well, Dr. Farmer, this might be something I look into.
There you go.
Poke us first.
Yeah.
Society.
Actually, this is probably going to be faster and cheaper.
That's probably
than
true.
getting yourself.
I don't got to buy a butterfly.
Focus in your practice. That's right.
Yeah, that is great. It's something that I wanted to ask you, Dr. Crowe, and this is just from my personal bias, and I might need to talk to you regarding this off air and stuff. But like, do you see a link in women in weight gain during that transition process? And could you just share a few tips on how you address that with them?
Yeah, I actually talked about this recently with the residents and the Oklahoma Academy of Nutrition and Dietetics. I presented with them, and yes, there is an average weight gain of 5 to 7 pounds during the menopausal transition.
Wow.
And even women who do not gain weight actually notice a body composition change, right?
Right.
So they get that increase in that visceral fat. So they'll tell you like, hey, the scale hasn't changed, but I've gone up 2 pant sizes.
Yeah.
Like, what is going on? So absolutely notice a correlation between weight gain and the menopausal transition.
Yeah. So how do you combat that, I guess, resistance training, or do you walk them through like maybe some weight loss medication or a nutrition thing?
So I always recommend a dietitian. I think that is fantastic and often underused.
Right.
And a lot of insurances are covering that as well. I talk about weight loss medicine, but with the understanding that it's kind of difficult to get the GLP-1s, right? Which is what everyone is hoping for.
Yeah.
So we talk a lot about just the lifestyle change that comes with menopause. There's a decrease in your metabolic activity at around the age of 50, menopause, right? And so they need to cut back about 250 to 350 calories to meet that change, right? They might have been the healthiest person ever, but when they go through that menopause transition, if they don't change anything in their diet, just that 250 to 350 calories every day is going to slowly cause weight gain.
Right.
I talk to, and this needs to be done before menopause, right? We should be counseling the women about this in their 20s and 30s when it really is going to matter and make a change.
Yeah.
The other thing is exercise, but not just cardio, right? It's not about running on the treadmill. It's not about biking. It's about lifting weights.
Yeah.
And that's not necessarily for the weight loss benefit. It's really to protect their bones, which is ultimately well, one of my biggest goals when I'm counseling women is to help prevent osteoporosis.
Yeah.
Exactly.
So
Absolutely fantastic. That is great.
Well, unfortunately, that's all the time we have for today. But thank you for joining us, Dr. Crowe. Thank you, followers, for joining us for this episode of Fast Talks with Family Docs, and we'll see you again next time.
Thank you for joining us today. The doctors would like to see you back for another check-in. Please choose to follow our podcast, and you will automatically be notified when it's time for your next appointment.